Great.
And I'll get us started.
Oh, great. Okay. So you're going to introduce, right? Yeah.
Yeah, and
Yeah.
I'll wait a few seconds before starting talking so it's so people come in the room.
Great.
All right, here we go. All right, people are coming in. Welcome, everybody. All righty. Welcome, everyone, to Renegade Research Roundtable. If this is your first time with us, thank you for being here, and thank you to those of you who are regulars with us as well. I am Isabel, CEO of our organization. We are a patient and caregiver-led, decentralized 501c3 nonprofit organization focusing on complex, multi-system chronic conditions such as ME/CFS and long COVID. Within this, we have 3 areas of focus: research that's agile and patient-centered, education to increase the number of clinicians treating us, and practical advocacy around barriers to care. Our work is made possible by our wonderful team of volunteers who move the wheels of our organization. Most of us have a personal interest in advancing research and care of these conditions. To stay in touch with us and hear about upcoming events, please subscribe to our newsletter and follow us on social media. We will be posting the links for you to have handy throughout the presentation. Our work also depends on donations of all sizes. You can help fund our work by donating to our funding campaign and also by sharing our campaign with others who can donate. Visit our webpage, renegade-research.org. On the roundtable today, we have Dr. Stuart Malcom from Rhythm and our medical director, Dr. John Haughton. Dr. Stuart Malcom is a provider at Rhythm Clinic and medical director. Dr. Malcom is an internal medicine physician. He started treating long COVID in March of 2020 and has treated many patients with this illness, including patients with post-vaccine issues. Prior to Rhythm, he was the primary care doctor with One Medical, where he saw how technology can advance medical care. He also served as a doctor at the Haight-Ashbury Free Clinic, the oldest free clinic in the United States. He understands the importance of access to care. He believes that Rhythm has the approach to cure long COVID, and he is excited to dedicate himself fully to this terrible illness. Dr. John Haughton, our medical director, has over 30 years of experience in patient care. He approaches clinical care from a systems perspective, also informed from his experience. He shares the approach with others and looks forward to the time when we are treating millions of people with long COVID and ME/CFS at scale with coordinated science-driven interventions. His current work focuses on effective clinical care approaches that quiet inflammatory and fibrotic processes using existing, inexpensive, accessible actions and activities that track the science and biochemical pathway. So without further ado, you can take it from here, Dr. Haughton and Dr. Malcom.
Great. Well, thanks for having us here for the clinical roundtable, and thanks to Dr. Malcom for participating. What we thought we would do is to just go through a few slides of background to just make sure everybody's on the same page of what we're describing, and then try to drive into specifics around the clinical approach from first visits to follow-ups to how much testing versus not, versus going straight to treatment, and how to keep up with the literature. And very importantly, want to be able to answer questions that people have. So as people have questions, there's a spot to put them in the website, and we're going to try to respond to those as a lion's share of what we do here. Dr. Malcom, do you want to make any intro comment?
Yeah, no, well, thanks everyone for having me. I've watched these talks before, and really reaching out to Dr. Haughton, I thought that it would be really more beneficial just to kind of talk. This illness, so ME/CFS and long COVID and other complex chronic illnesses, this just exploded, and it was ignored, and there's just not enough people doing this. And so getting to kind of communicate and share ideas, I thought was really helpful. And then I'm looking forward to questions, because I feel like there are lots of patients out there that are just really pining to have one that specific question answered. And so I'm really happy to kind of jump in when I can for that.
Great. So I'll go ahead and flip through the initial part of the presentation and just double checking. Are the slides showing? Stuart, can you give me a thumbs up if you're seeing the slides on the screen?
I can see it's still cut off a little bit on the left.
Yeah, then the left side of this graphic is just a composite. It's not
Okay.
it's cut off, so that's perfect.
Okay.
So some of this was done, so it kind of took our clinical process and thoughts, and then it used Gamma that helps with graphics, and then edited afterwards. So that was a new learning experience for me, and see how people like it. Yeah. All right, there we go. So we think about this as a system of inputs, and then the body's processing and their outputs. And so there are external factors. It could be infections, viral or bacterial, pollutants, microplastics, air pollution, injuries, mold. And then internal factors can be chronic stress, which can raise the fight or flight sympathetic responses, and then autoimmune signals also can raise the inflammatory burden in the body. All of that gets processed and sort of mixed together to say how much is somebody in a state of inflammation and breaking things down, or in a state of building and having additive processes. And in the breakdown phases, you end up with lowered energy production, and blood flow tends to restrict more towards the central part from the periphery, and that can cause ongoing inflammation as you get more hypoxia. And so the bottom line of it is, whether it's COVID or a tick bite or a combination or mold or a layered collective, you start inflammation, and once it starts, it's possible to get capillaries not having enough blood flow. And when that happens, you get hypoxia, or loss of oxygen in the tissues. And the result of that is to create more inflammation. So once you get into the loop, you can get stuck there, and then you've got to figure out how to break out. So again, the triggers can be multi-layered and multi-steps, from trauma and autoimmune. They could be both physical trauma, head injury, psychological stress trauma that's happened to people in the past or is ongoing, as well as intrinsic inflammatory pathways. Somebody has more of a predilection towards rheumatoid arthritis or another autoimmune disease, then that is going to give you more inflammatory burden. And then externally, the bacterial, Lyme is a perfect example, viruses, Epstein-Barr, COVID, and so on. And then molds can exacerbate as well. And collectively, all these things add up to be more than any one alone. What's happening inside the body is there are danger sensors on cells and inside of cells that they're called the toll-like receptors. And when they're activated, they start the inflammatory cascade. And so if you have lots of activation, you get more inflammation. If you have a little bit of activation, it quiets things down and resets the teeter-totter. It's really the danger signal for the body. And then downstream in the once you get inside the cell and into the nucleus, you have various pathways, and NFKB, the killer cells, will come up, NLRP, inflammasome, just sort of creating the cytokines. There's something called the RAGE pathway that can be part of it. Heparin helps to quiet that down. It's one of the reasons heparin's helpful for some people in this in the collective of disease. But the end result is the release of the inflammatory particles. That further inflames the blood vessel, limits more blood flow, and then this thing called HIF-1 gets driven into the cell that drives the inflammation. And it's the self-sustaining loop is the issue. So you can end up with capillary loss. You can end up with blocked blood flow from microclots, and those will get you into this hypoxic state. And at that point, you've lost energy, and your cells start to work in a place without oxygen, which is a less efficient energy. And you'll hear glycolysis versus Krebs cycle or TCA. And when glycolysis is the mainstay, just not as much energy is getting produced because it's an inefficient metabolism. It can work very quickly and it can work in low oxygen environments, but it's not very efficient overall. And that's related really with the post-exertional malaise. It's not just tired, and there are plenty of studies that have come out and are coming out showing changes, and the hallmark being you exert one day and it takes a while for your body to recover. It's not just being tired. And the end result of all those things at the cellular level is the impact on the organ and the person, the brain fog, the breathing, GI, cardiac, and so on. And then, of course, the impact in it, as we are members of society, it makes it harder to work. It makes it harder to be a parent or a child. And so many things can happen downstream that all comes back to how do you get inflammation down and blood flowing? And we're going to talk about that clinically. This is just sort of showing that it's just that signaling and the combination. It's a cycle, and so as you get the pattern recognized, hey, there's danger, turn it on, and you start increasing the inflammatory components. Microclots can be a first part or a second part. Once you get slow blood flow, you can get the microclots. The microclots can form as monocytes come in, and you end up with the blockages in the capillary that lowers blood flow. Either way, you lose flow, you lose oxygen, you increase inflammation. When you increase inflammation, you get leaky vessels, starts the whole mast cell process, breaking down the glycocalyx, the vessel wall covering that usually keeps things smooth and moving, and the overall chronic hypoxia disrupts things. So it's a blood flow, inflammation, hypoxia issue, and then the mitochondria changes how it works. Creates all sorts of symptoms across organ systems. And just pounding it back home, the convergence of multiple things on the way in could start with the vaccine, could start with the infection, could start with a tick bite, then you get an viral infection. It could be living in a moldy house and get one or another or some combination of those, and ultimately creates ongoing inflammation that lowers the efficiency of energy and creation. And so the therapeutic targets and what we want to talk about here in terms of treatment is looking at pathways and how to do it. And, why is low-dose naltrexone used? Why is curcumin used? Why are antivirals used? How do they all interact with each other? And so this is the summary and the kickoff of what we're going to be going on for the discussion. I'm going to, I think I'll stop the sharing and turn it over and ask this the first question. Stuart, your approach to the initial visit in terms of how complete of the initial visit, how to get things going, what happens? What's the most pragmatic one? And maybe touch on the rhythm. You've got the some of the rhythm direct. You've got the rhythm with the full clinical interaction. And then I'm happy to share some thoughts too.
Yeah, no, great. So I love the presentation, and I think that this is something that I've gone again and again in my head. The initial insult of the microclot. So I guess I'm going to take what Dr. Haughton said, and I want to give a little bit of commentary, and I'll kind of jump into your question. So I think the first thing that did happen, at least very early on in long COVID, was that I do think it was a microclotting event, and that there was something very bad about that initial virus that caused a clotting cascade, and I think that was the initial insult. And we have good evidence now that we can. There are kind of papers out there. You can define long COVID as a vascular inflammatory disease. Um, Obviously, there's a lot more than that going on, but the South Africans originally treated this very early on, long COVID, with blood thinners and had really good results. But now we're in a situation where that process has then gone down another hole, and it's changed the metabolism, it's changed the tissue, it's changed a lot of things, and then the kind of biome that exists in the gut or in the sinuses or wherever are now kind of affecting all of this. So I just kind of like saying that because I think that that was how I thought about it. But I think, John, what you're saying with this ongoing hit to the capillaries and to the endothelium is something that I think about a lot as well.
And just a quick comment that people may be familiar, but I think it's useful to say that it turns out that the spike, what people refer to as the S1, from a research perspective, it turns out it's in these ideas of receptors being locks and keys, where if the key fits into the receptor, then the receptor it does what it does downstream to create proteins or what have you. The receptor that normally responds to gram-negative bacteria wall, what's called the toll-like 4 receptor, it turns out that 3 spikes together fit almost perfectly into that receptor to turn it on. It also turns out that Ebola and RSV can fit in there as well. So it may well be why we're seeing RSV on top of this. It could explain by itself why some people with a vaccine injury end up, because if you have spike produced and it starts this process, you can get the inflammatory process going that self-sustains. And then right next to the toll-like 4 is the toll-like 2, and that's what makes Lyme disease is the key that fits into the bacteria for it that fits into toll-like 2, and both of them go down the same pathway inside the cell to turn on the innate immune system. So what you were saying about what starts it, the anticoagulants and so on, that microclots are absolutely at the core of this.
And really, from what you're saying, the hard part about this is the world's medicine's understanding of what the insults are and how they're different in everyone. And I think I've been treating long COVID now for more than 5 years now. And I remember being like, no, it's a virus. It came in, the virus, you kill the virus, or you get rid of that's what it is. But there are multiple papers, and I think as someone who was very kind of very academic and very this is how this is what evidence-based medicine is. It's like you kind of get a little stuck. Medicine kind of gets a little stuck, but there is evidence out there. So John had mentioned like mold. I will often the chronic kind of mold medicine world has had to live off in like left field and has really kind of like not gotten what it needs in terms of modern medicine. The paper I point to, Michael Peluso, Timothy Hendrick, they're part of the UCSF. They have their big lab there. Compared to controls, 7.1% of long COVID of controls had fungal material in their blood, whereas a third of long COVID patients had it in their blood. So it takes this idea of what is long COVID? Is it from a virus, or is it virus plus everything else? It's the same thing with Lyme disease and Bartonella, all this sort of stuff. We didn't have the understanding beforehand about how common this was. And it really is a shame because there's been this area of medicine that's really been pushed off into the side. So, there was a recent Senate hearing with RFK. I always tell people, here's politics, like long COVID and ME are too important, like get out of here. Like I don't care about politics, but really during that hearing, it was talking about we're going to recommit to long COVID. That was the very first thing that was talked about during that hearing. And so that makes me happy. But really the mention of Lyme, and Lyme is this really hard thing about what we don't really know. And so I always tell people a bit of this is an issue with clinicians coming into this and feeling like that's not a real thing, blah, blah, blah. We're going to get the data that really proves what is going on. It's just we're in a tough position right now. So I just really wanted to start with that because that's just an important thing to say. I think just for your first question of like, where do we, the general approach to the first visit, I think John was the question. Gotcha.
Exactly. Yep.
So I do kind of just want to give disclosure. So I work for Rhythm, RTHM. We're a telemedicine company. We provide care like a traditional medical model, but we do have other products. So we have something called Rhythm Direct, where you can directly access medicine. The idea being there are millions of people with long COVID and ME/CFS, and not enough of Dr. Haughton and myself and other people to really kind of go around. Can you get access? And I really want to mention this because low-dose naltrexone is something that we offer. I would hate for people to think, oh, I'm telling this because that's what Rhythm Direct offers. It's a drug, it works. It's just something that we want humans to have access to, like in the world. So I think so that's just my disclosure. I'd say my first approach on visit one is this is really hard. Sometimes the first visit is patients are seeing me. Sometimes patients, they're coming to me, they've only been sick for a few months. And things that I talk about with my patients that have been sick for 4 years are so different. My patients that have done this for 4 years and they find me, they're at the bottom of the internet with me, looking at all the research in the forums, talking about this or that. And then you have other patients who they haven't been through what I'm going to call the trauma of this of all of the ups and downs of this illness. So I want to say that because we have something called the art of medicine, as clinicians, where if someone's coming to me and they've been hurt, they don't want to try a whole bunch of medicines. It's like, okay, we're going to start slow. And other patients are like, I want to do everything possible. So I really just wanted to mention that as just like everyone's different on how they kind of want to approach their care, because it's their life. And you really need to hear the patient. I think the other thing that I just always want to underline to people is symptoms. So what type of, do you have ME/CFS? So ME/CFS is a clinical diagnosis. So really underline people like, what is long COVID? There are more than 200 different symptoms behind it. And do you have ME/CFS as a part of it? Half of long COVID has ME/CFS. ME/CFS you can diagnose with a CPET or through specific guidelines, the Canadian Consensus Guidelines or the 2015 Institute of Medicine guidelines. And so really kind of telling people, hey, you have these symptoms. If you're coming to me and it's kind of been, we don't even know what you have, do you have long COVID? Do you have ME/CFS? Do you have POTS? What part of things in long COVID do you have? Do you have chest pain? Do you have tinnitus? Do you have brain fog? Do you have gastrointestinal upset? Because we don't think about cancer this way. We don't think, oh, I'm an oncologist, you're coming in and you have cancer. It's like, no, you have lung cancer. You have adenocarcinoma of the lung. You have a mutation that's like this. We're not there yet with long COVID. And it's so difficult to take a patient where all of us doctors and NPs and PAs are used to, hey, you have diabetes, here's the drug that I give you. This is about a very complex heterogeneous disease. So I start with, hey, what are your symptoms? And I often go like, give me 1, 2, and 3, or give me top 5, or give me top 10. And I'll tell people, my patients, I'll go, we really want to make sure that I'm aware of what you're feeling. Because as Dr. Haughton kind of talked about, there is a complex pathophysiologic mechanism that's happening. All of a sudden, millions of people didn't get ill from nothing. There's something going on. It's real. There's something there, but we're trying to catch up. But I have to go to, I'm trying to figure out that biochemistry, but I also can give you medicines or drugs or techniques or whatever to help your symptoms so that you can feel better, so that I can continue the work. And so I start with symptoms. hey, do I have PEM? Okay, we got a pace, and then there's a few things we can try. Do I have fatigue? Okay, there's some things we can try. Brain fog. And so it kind of goes down the list. So my recommendations to patients would be keep that list of what's the worst thing. If I could get rid of one thing, oh, I could work a little bit more and have that ability to live my life a little bit, more. So that's important. The other way that I really kind of want to talk to people on their first visit is the workup. So just a logistical thing, and I really want to just be cognizant of everyone in the audience here, which is some of the folks who are in the audience, they've been sick for a while. They're like, Dr. Malcom, shut up. Like, I want to talk about the most complex medicine. I really want to get to what I've seen logistically, which is we have to be organized. So save every single lab that you've like ever got, because if you go to one hospital, one clinic, you come see me, you come see like someone else, labs are kind of all over the place. So make sure to kind of like save them. Some of my patients have had many extensive workups already. Okay. So I start with the simple workup, which is let's run tests at Quest or LabCorp or your kind of local hospital or clinic. Okay. So I really want to make a point of that, because in the patients who are lucky enough, I guess, to say that they have insurance, we can get some of that covered by insurance. Hey, this is at Quest or LabCorp. We can go do that. On the other side of things, there's kind of the world of what I would call functional labs. Okay. And I use those quotations because I remember being a doctor and having people coming in and looking at this test. It's like, oh, what's an organic acid test? Like, what the heck is that? I've never seen that before. Therefore, it is wrong. And I'm embarrassed to say that I felt that way. But there is very much a sense in medicine where if you see something you don't understand, I think that the good doctors and clinicians out there will go, okay, don't understand it. Like, make sure that the person who ordered it really follows up. Just because you don't understand something doesn't mean that it's wrong. And that doesn't mean that it has some sort of validity. There are a lot of companies out there that are developing new assays to really kind of identify biology and things that are going on. So I start with the tests at Quest and LabCorp and kind of the local hospital where I can look at stuff. But I do tell people I'm going to want to look at tests that are a little bit more complicated. I want to look at your gut. I want to look at an organic acid test. I want to look at a cytokine panel. And the logistics behind that are really difficult. They're going to be a kit that's sent to you. You have to do X, Y, or Z in order to kind of get it accomplished. And these things are unfortunately not covered by insurance most of the time. So things add up. I do really want to underline to patients, hey, I can quote the data that I think something's wrong with your gut and you're having some gut symptoms. We're going to do a test, but we should really follow up with it. And that is going to also incur some cost. So my experience as a former street medicine doctor, it pains me how expensive this can be. It really is painful. So that's kind of my first approach, which is symptoms. And then I really want to talk about testing, do the easy test first, and then really kind of introduce that there's other tests out there. But then I also want to start talking about medicine. So I think the hard part in this field is someone comes to me, they've been really devastated. We want to kind of hit the ground running. And so I think there's going to be people in the audience being like, okay, I've already tried low-dose like naltrexone or LDN. I've already tried that. I've already tried that. I've already tried that. What's coming down at the bottom? We'll talk about that. But there are certain things that you can start right away that, in the community, talking about the kind of the long COVID or ME Bill of Rights. What are easy things that you can start right away? So low-dose naltrexone, super easy, something to kind of calm down inflammation. So I want to kind of pair with the patient and talk about what can we try right away that I just know works and that can help you. It doesn't mean it's going to work for someone. And what I mean by that is I have patients who took LDN and it worsened them. This is the horrible part of this illness, is that you will try something and patients are like, I don't want to get worse. And you feel very confident that this is a drug that's going to help them. But I've seen people get worse from pretty much everything that I've ever given as a long COVID doctor. I really just kind of wanted to state that. The last thing I wanted to say is in medicine, there's this very much this tradition of what is the evidence-based medicine. So I came from a very cardiology-heavy internal medicine residency, and I could quote all the papers in cardiology about this was the trial that proved that this drug was good for heart failure and blah 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 blah. We are not there yet in long COVID. We and ME/CFS, we are not. There are some studies out there. So I often will kind of point to things and say, here's the study, here's the randomized control trial. So Dr. Yelman was on this in this webinar a few months ago. He and a few colleagues published the oxaloacetate paper in ME/CFS. Randomized control trial. This is the truth. Like it's the best form of data that we can get. Can we give you something that has very good evidence that will help you? Now, again, oxaloacetate, what that supplement is it fits right into the Krebs cycle and allows you to allow the Krebs cycle to work so that your mitochondria can spit out ATP and energy. It still didn't work in everyone. So I really want to underline that there are evidence-based medicine like techniques that you can use, but really identifying, hey, there's still not a lot, and we need to kind of move on from that and try things that we know have at least empirically worked. I know that was a verbose answer, but I'll turn it over.
No, I think it's good, and I think there's a lot to connect with there in terms of I mean, one thing a randomized controlled trial says for this group of people, here are 100 people. I'm going to put 50 of them on a placebo, and I'm going to put or an active drug, and that's the comparator, and I'm going to put 50 of them on what I'm testing. And is there a difference between those groups? And you can have a positive trial that's clinically meaningless. The people who took the placebo had 2% less than the people who took the drug. On the other hand, maybe it's a 50% difference, so it's huge. So the trial can be statistically valid and show a difference between the groups, but there's the clinical impact of it that's important. And then the converse of that's also true of in a trial that has a limited impact or that's not effective at all in terms of statistically the two populations look the same. If you start going into responder analysis to say, well, what's happening? Why are some people getting 70% better and some people it doesn't affect at all? And that could be where they are in this process that we talked about in terms of, are they on the breakdown side or the build side? Do they have blood flowing? If you don't have blood flowing, then you may not be able to get that drug into the tissues that need it. And so, and equally, if the LDN is an example. LDN, one of its mechanisms also is quieting the toll-like 4 receptor. And so if that's the causative issue at the time, it may be very helpful. Turmeric, curcumin does that. Berberin, Metformin do that. There are other ones as well. And but at the wrong time, it may not be as effective. Or combined with an antiviral early on may be critical, and later on it may be super important to break apart the microclots and quiet inflammation that way, or some combination. And I think that for me anyway, when I started my clinical practice or clinical activities, and I've done a combination of clinical and administrative things over the years, and swung now back into treating and working with patients with long COVID. And there was chronic fatigue at the beginning of my clinical time was in the early 90s, and it was chronic fatigue, and we just sort of threw stuff against it, and sometimes it would help a little bit or sometimes not. And fibromyalgia, but never really knew what was going on. And I think that because with COVID, we had people who had vaccines and we had people who had disease, and we knew it at a time, and they were healthy or unimpaired before that, and then had a decrement in function, you can see more of a cause and effect that starts to say, well, what's happening at a system level? And I know there's one question in the Q&A. Somebody's asking about information for their hematologist about microclots and anticoagulation. That absolutely is one of the sort of known cores at this point. The groups, Pretorius and Bell and others out of South Africa have some of the strongest literature on that. But at this point, I don't think that there is much controversy around that microclots exist and they do cause problems. And when monocytes come in and they get activated and they create nets and they trap platelets and they plug up like little corks in the capillaries. And so now we can get at the system approach of what's happening. And so the therapeutic answer, it may be critical to say, I'm going to give something to quiet inflammation. At the same time, I'm working on some viral persistence and trying to get more short chain fatty acids, say in the gut, to give raw material or make sure minerals and vitamins are at the right levels, so the raw material to repair things is available. And that collection can make the difference and make something that's not working all of a sudden work. And one last thing, and then I'll stop for the moment there, that if the core group, there was something that just came out in the last couple of days, somebody published looking at what's called BRFIS, which is a nationally representative sample of hundreds of thousands of people, and found that in the 2022 BRFIS, the survey, about 7% of people had long COVID. And the group that ended up being at the pinnacle of that, or the groups, were women in their middle-aged women. And interestingly, wasn't in the paper, but as part of it, there's some of the hormones in the cycle change the inflammatory burden that exists. Luteinizing hormone, when it changes through the cycle just before the period starts, that is a material change in the inflammatory and anti-inflammatory burden that the body is seeing at that moment. And so you have more inflammation going on if you're not changing anything of the meds or other things come on the way in. So it's important to look at the nuance here too. And I think that Stuart, that you were absolutely speaking to that you've got to personalize what you're seeing, and then is somebody wanting just a straight answer? Okay, here, I want to try something, tell me what to do. Or are they a partner wondering, hey, is this going to work or is that going to work, or what's the first step? And I think for me, that's one of the challenges in the discussion. It's also one of the delights, is to understand how to meet the patient where they are and what their need is, and then try to work forward. And the good news is, in general, the people can be severely affected, and in general, it's not a second to second, hour to hour issue. It's unfortunately, people end up in states of decreased function for decades with ME/CFS and long COVID. So it's important to not do harm also along the way.
Do you mind if I interject real quick? Because I think from that question, what I get at is, I'm seeing a hematologist and I know that there's this microclotting phenomenon. From 10 minutes ago, you and I are talking, is it in the initial insult? I think so. Is it still going on, or what we call spikeopathy, which I don't think is going on in everyone still, where they still have spike protein or persistent COVID in them, but is the HIF metabolism, the hypoxic metabolism, still going on to create a microclotting environment or an endothelial damaging illness? So, but really what John is saying is, there is good evidence that there are microclots and vascular inflammation, period, and stop. When I started giving blood thinners to patients 3 years ago, I very much felt out in left field. And that's an uncomfortable position to be in. But what I get up from the patient's question is, I have to go see a human being who is a clinician, and I think this is going on in me. Or how do I investigate to see if this is going on? How do I, one, get a drug that potentially could work, or two, do a lab test that will show this? And really the hurdle here is the clinician and in their familiarity or unfamiliarity with this phenomenon. So I want to say it's hard on patients to I've had patients early on who they were like, Dr. Malcom, this is a microclotting disease. I'm like, oh, and normally I have to convince you that something like that's going on. And they're like, put me on blood thinners. And I've lived it where I'm trying to find this phenomenon in someone and I want to attempt a medicine, whereas the patient, wants to do it. I often tell my patients, I want to do something, I want this to be safe, but I'm a partner here. But that's not everyone. If you see a hematologist, they might be like, I'm not going to do this, blah, 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 like that. I'm not going to do that. It's hard because these are blood thinning medicines and they have risk associated with them, but there are people out there that are doing this. So I would approach the hematologist kind of in the following way. I would give them the papers. So there's what I call the Ang1 P-selectin paper, Doug Fraser's group in October 2022 out of Western University in Canada really showed this to be a vascular inflammatory lab. There's Owner Boyman's work in Europe about the complement system. There's a recent paper about the kind of the capillary refill or the how abnormal the capillaries look in the fingers. There's papers about the retina and how it looks different. Arming yourself and going to somebody like, here's the evidence. You like I don't have the choice of going to another doctor or whoever. Here's the evidence. And then the clinician be like, okay, well, like we'll give it a try. Or they might be like, well, like let's do some testing. So testing wise, there are cytokine panels that show elevated VEGF, vascular endothelial growth factor. It's the factor that the body secretes to say, hey, I'm going through hypoxia. That might be an evidence to show this. I do want to take a bit of an aside. Quest Diagnostics, their VEGF is really, I don't think, representative of what's going on. If it's low, mine was low. When I ran it on my when my doc ran it on me, so I don't think that's a good test for that, but there are other good tests. Looking at thrombin antithrombin might be something that's good. The cytokine panels that I mentioned, endopat used to be a thing that people used to detect vascular flow. I'm not so that's something that you can look at to really prove that's what's going on. And then the medicines. I have used what the South Africans call triple therapy. Eliquis 2.5 to 5 milligrams BID, clopidogrel 75 milligrams daily, and a baby aspirin. Aspirin, again, everything has risk. I've done a lot of that. I've done a lot of clopidogrel. I've not really seen ill effects, but I have had people bleed. When I have treated people with blood thinners alone, years later in their long COVID, some people had astronomical improvement, but the vast majority did not. And that is what, Jaco Lobschner, really warned the world in long COVID, like you have to do this earlier on or you're not going to get that benefit. But those are pharmaceutical drugs you can try. I really want to give patients like understanding of what can go on. So Jardiance, which I think is also called empagliflozin. I've not had issues with it getting it covered by insurance. Here we're in the United States of America right now. So really been an okay drug. It can make you pee more. But that seems to help with the reperfusion injury. People are noticing some benefit. People are talking about the GLP-1s, Wegovy, Ozempic, hard to get through insurance, but that might be helping the endothelium. I think Metformin is one. SPM, there's all the supplements, SPM active, things that help the glycocalyx, Vasipa, which is very highly purified EPA. There's a case series on that, on helping long COVID patients. So there are tools, but really the way, and to kind of, sorry to hijack the question that I got from the blood thinning was, how do I convince a clinician to go down that pathway? And the answer is, for some people, you just can't. You know what I mean? You can't. Go to an academic long COVID clinic. They might be, they should be able to offer some testing like involved with that. I've listed the tests that I consider to be kind of helpful on this, and all the different supplements. We didn't even talk about nattokinase. That's been helpful. It does many different things, but there are things you can try. It's just been very frustrating for people. And so I really hope that we get more clinicians that are following the data and willing to kind of try. It's uncomfortable for people, but it's something that has worked in people.
Yeah, that's super, I think is super helpful. And as you look down at the mechanisms, so is it triple therapy or is it specific things you're going after and why? And it turns out that one of the pathways that's increased is the RAGE pathway, it's called. And it's also known as the S100 A8 A9 pathway. And calprotectin is another name that gets in there. It ends up in the GI realm, but it's also in this capillary realm. But a key part is that heparin is is a really good attenuator of the RAGE pathway. And so if you stop and go, well, what's happening to increase microclots? That at the capillary level, and just briefly describing it, you've got the inflammatory cells, the monocytes coming in, they activate, they throw out nets that can trap platelets and other things that can create a microclot directly, or they're inflaming the edge of the wall and breaking apart what's on the capillary wall, what's called the glycocalyx, and roughening it up, which makes a leaky capillary. And when that happens, you end up with infiltration of some of these inflammatory cells into the tissue between the capillary and the lymph. And that's where the mast cells live. And when the mast cells degranulate because of this activation, you end up with increases in what's called von Willebrand's factor and the intrinsic clotting cascade around platelets. And platelets have 3 receptors on them and so aspirin hits one, clopidogrel hits one, and the other one gets hit by some specific antibodies. And the combination of low dose or low molecular weight heparin along with a baby aspirin, maybe from a systems and a biology perspective, is hitting the areas that are getting boosted up and may be helpful. And some people have had just remarkable early effects with the low molecular weight heparin. And then if you think about what's going on, well, okay, you get low molecular weight heparin going in there. Let's say you're breaking apart the microclots, then now you can get raw material in to start acting on the inflammation. Or to your point about nattokinase, it's one of the most effective ways to break apart the microclots. Nattokinase, lumbrikinase as well. Some people have soy allergies, so that ends up being an issue on the natto. But it can work really well. But once you break that apart and get blood flowing, you've got to bring the other pieces in to quiet the activation and the inflammation. And so that's where the TLR4 things, the low-dose naltrexone, the curcumin, and metformin, and so on, can be effective. And then the raw materials getting them in there is related to the potentially then changing the microbiome, and so that's things that'll work with short chain fatty acids in the gut, sometimes extrinsically given, sometimes boosted by things like berberine and metformin. But you can really you can walk through where are you and try something, and then if you don't get a response, it says, hey, maybe I'm not at that phase, or maybe I've got to go into an earlier phase along the way. And this idea of the phased pathways, the preparation of the body as well as the intervention, is something in the remission biome that Renegade Research did. There's the initial phases that are to kind of get the body ready to go, and then you give the antibiotic to see if there's if you break the energy chain or change it. The Born Free protocol does something similar with that, of boosting and prepping the body, and then going in after the activities. And so timing is really important here too.
I think I did want to piggyback just on the comment you made about heparin, which I started doing triple therapy because that's what the South Africans did. And I think that patients sometimes need to understand, like clinicians, we're anxious. You know, we're like, okay, someone else did it. Okay, I'll give it a try. I've heard, I didn't jump towards heparin because it's harder to give. It's an injection. But we're seeing signatures like that heparin are better. So it's exactly what John is saying there. There are other drugs, you know, solodexide. The TON-CoV study out of Tunisia came out very early on using a drug called solodexide, which has heparin-like components to it and will help the endothelium. But that's not available in the United States. So there's a lot, and I want to underline that I agree with you in terms of the mechanism and the staging of where you're at and how complicated. But my heart goes out because we need time for clinicians to think and to act, and to do things. And right now we only get 15 minutes with patients, and that patient might not have time with their hematologist to really kind of talk about this. So yeah.
There's and by the if you are outside of the U.S., solodexide is essentially oral heparin. When it gets metabolized and breaks down, and so you end up with essentially active heparin, but from an oral perspective. And so that certainly mechanistically will act on the RAGE pathway. There's a question here about cheap and accessible commercial DNA tests to getting a grip on SNPs or single point mutations, and that may impact things. There's a lot of discussion. It's not part of the question, but a lot of discussion around methylation and the mother variant, and does that make a difference, or are there other ones? Are you finding that getting the genetic profile is useful to your clinical work, Dr. Malcom? Or
yeah, so this is just me being very kind of like honest. You know, so I used to think of long COVID as a microclotting vascular event, that you were holding on to spike protein causing this, or holding on to the virus, or you've made microclots and you just need to fix that. But it's so much more. And with the lack of oxygen going into the tissues, you're going to change metabolism for everything. So, you know, we have 25,000 genes or so in the human genome, and there are cofactors for each thing. So, for example, there's you know, a survey of ME/CFS patients showing that high dose vitamin B1 really helped with fatigue. Why would B1 be helpful? Because we use B1 in many different ways. We use B6 intracellularly in many different ways. We use iron and heme and so many things. So once we have an effect, we have then a cascade. And that is the hard part. So to answer your question, yes, I think that the genetics are fundamental for understanding, but am I the expert at that yet? No, not by any means. I think the problem, and I have to reflect back being a doctor, where people would come in excitedly, even before long COVID with their genome, they'd say, hey, here's my genome, like, what do I do with it? And again, I'd be like, I have 10 minutes with you. What am I supposed to do with it? So companies will make products like, oh, like you should consider being on like you know, a fish oil, or that you have an MTHFR mutation and you need to have methylated things or whatever. So to answer your question, I don't have the answer to that. I'm exploring that, but I think that it is really fundamental. And I think because we know this illness is not just one thing, it's the effect of everything. And hey, say I have a mutation in a specific gene that I now have a dysbiosis, and that bacteria is eating that cofactor, and my gene is downregulated and I take a hit. Well, that's my long COVID or my ME/CFS. So I honestly think that that's the answer. I can't prove it, but I think that's the answer of really thinking about because the genome is the genome. Everyone's is different, but then you have the hit, and the hit is everyone's genome is different. You have upregulations and downregulations, some deficiencies, some overactivations, and then you get a hit, and then it kind of bottlenecks into a biochemical reaction. But how do you make that decision? Because what you really need is metabolomic studies. So we have many different words for these things. So like the metabolites will go up or down according to a blockade in a genetic pathway. And we're not quite there yet, but what I would really emphasize to people is looking at products, like looking at SNPs, where you have a pathway assigned to it. And what I mean by that is so for example, the tryptophan pathway. The tryptophan pathway can convert down into melatonin. That's why when you eat turkey, you get sleepy, or it can go all the way down to NAD+. And so there's a randomized control trial, I think it's a randomized control trial, using NAD plus, which can be an injection and up the nose or as a patch, plus LDN can result in reduction of fatigue in long COVID patients. The tryptophan pathway goes all the way down to NAD plus, and an interruption in that will cause an elevation in quinolinic acid and the kynurenine pathway. And that's been written about, I think, from an Australian group. I can't quote the authors on it, but what's the gene? What are the genes behind that? Why doesn't every patient have that? It's because everyone's kind of different and how the initial insult then resulted. So as a long answer, I'm not going to give an answer, because I think that really you need to think about it as a genetic platform that would offer an idea of how everything is interconnected. It's not just, oh, I've got a mutation here, what do I do with it, doctor? It's, no, how does that relate to everything? And well, how do I prove that you have a SNP that's like kind of abnormal, but like, is that an upregulation or a downregulation? What are the tests that are around it that would prove that to me? And I know there are folks out there in the universe that are working on this. I'm not quite there yet. But I'm excited about that prospect of long COVID and this for all of medicine, to be honest with you.
And the concept of very specifically of if it exists and what would the impact, and if it's impacting, what would that impact be? And so how can I test that on raw material and substrates on the way in or effect on the way out? And I know Kat's come up on screen here and has done a lot of diving into the details with some of the in the remission biome cohort around some of the glutamate changes and things. And Kat, go ahead and share some of your observations. They're intriguing.
Sure, sure. First, I'd like to say I would really, really love to emphasize that comment you made about looking at these as pathways and not as single traits. Like that is so important. And it's something that is unfortunately really missing in terms of sort of, traditional systemic medicine currently. Usually they'll test for one or two variants of one gene and nothing else. When, every gene has dozens, hundreds of variants, each individual will have many SNPs at a single gene. And then there's all the genes that are next to it and the interacting pathways. Like that's so important. I'd also like to highlight that last thing that Dr. Malcom said about it's also important to check what's actually going on in the patient. Regardless of what the paper says, regardless of what the gene says, it's important to check what's going on, especially with something like ME long COVID, where we know that a lot of this disease is epigenetic. So it is about changing the expression of genes, whether it's increasing HIF1 or TLR4, or whether it's decreasing GLT1 class, which are some of the glutamate transporters that I've been looking at. Looking at what's actually happening in the patient is super, super important. In the Q&A, they'd asked about available testing. Obviously, going whole genome is, better, more information, always good to have more testing done, more information at our disposal. But in terms of accessibility, even just like the basic ancestry tile, whether it's ancestry.com or 23andMe or any of those others, even those are going to provide a ton of information. I got that done for myself about 2 years before I got my whole genome. And I was able to make a lot of interventions based on that data. Now, I don't use their health reports. Those commercials are not worth their health reports. Those reports are not good. And in fact, they will often tell you things that are just flat out wrong because they're looking at single gene, right? Rather than looking at the whole picture. But you can take the raw data from that and run it through something like Genetic Life Hacks. We've actually been working with Debbie from there to make a custom panel with some of the genes that we've seen be, sort of overrepresented, some of the variants that are overrepresented in our cohort. So we're hoping to make a custom panel with her. Or there's also, programs like Prometheus that you can just sort of read through your raw data on your own.
And this is I think is an important piece to, a lot of us end up kind of being familiar because we immerse in it, but to share with the group at large here that you can get a test, for example, at 23andMe or a different one, and download the raw file and then upload that raw file somewhere else, and they can use the same information to create a different report or format and so on. And that can be very helpful. So if you've gotten the test, that can be very, very useful to get your raw data. I just wanted to share this idea of the pathway. I wanted to share just briefly my personal story of how to come back into treating long COVID, and it really was from having it and having been having a cancer when I was a kid, and I stumbled into Metformin trying to work on a radiation issue that I had with a skin wound. And it was helpful to keep the wound intact, but I found after a few weeks it cleared up some brain fog, and this was in, the fog kind of started in 21, 20 in that period, and this was going on towards 22, and Martha Eckerly had done her surveys online that had found that nattokinase was very effective in terms of people's response of saying, hey, what worked? And so took that and started diving into the mechanisms and found it to be really helpful. It was what turned me on to curcumin, and it's how it's so super accessible. If you get it to the right doses, you've really got to get about 500 milligrams of curcuminoids, which is a lot more than you typically have in most of the supplements. You can get the supplements that have the higher ones, but you have to be very careful about the wording on the labels. Do they really have 500 milligrams of curcuminoids, or are they 95% of a small number? There are a lot of tricks math-wise that 50 milligrams can look like 500 milligrams. But anyway, and those all quiet the TLR4 pathway, and then found that, I don't think it's for everybody, but personally then going to some pulse senolytics made a big difference. But it was after doing some of the other stuff first. And I think each person that goes through the chronic inflammatory process ends up with their own understanding of how their body responds. There could be seasonality. There could be, if it's a woman, there could be monthly cycling associated with it, and so on. And to really listen to those signals, because of where do you put what piece in? And the last thing I'll say, and then to turn it back to the group here, is I had some pulmonary fibrosis from lung radiation that started 40, 50 years ago. And this treatment pathway took my pulse ox from 92, and now it sits at about 98%. And my energy and my wind is better with it. And so that gives me a lot of hope that this stuff is not completely irreversible. You can go into a fibrotic state, but the body is continuing to repair things. And I've got a very small amount of quantitative evidence around that, but it gives me hope when I talk to people. I get the question a lot, well, am I stuck with this forever? And the answer is not necessarily.
That's great. Back to the question from the person in the UK, in terms of specific tasks, Dr. Malcom, when you do that initial visit, what are some of the common tests that you tend to order, and what is specific to inflammation?
Gotcha. Okay. So just like as a bit of an aside, so there's out of the Bateman Horne Center, like treatment with valcyclovir and Celebrex can help patients. So does the patient have a type of herpes virus reactivation called the Epstein-Barr virus that's well known in long COVID? So looking at an Epstein-Barr virus panel, I literally saw someone yesterday and they said, oh, my EBV panel was negative. What does that mean? Because when I used to be in my former primary care life, I wouldn't run like an early antigen D IgG. So there's the early antigen D that's not necessarily a part of like the panel. That might be indication that Epstein-Barr virus has been reactivated. I do not think that the EBV DNA PCR is all that helpful. I've actually never seen that to be positive. That might indicate, hey, let's try valcyclovir. We just spent 30 minutes talking about how complex long COVID is and all these pathways, but there are things to try that it's like, hey, can we just try valcyclovir on you? So anyway, or famciclovir, or Truvada, which is coming out as a potential treatment, potentially for EBV, COVID, or CMV. We're not sure. So that's a panel. Most people have come to me with that, so I just want to kind of clear that up. There's more advanced testing. So there's testing out there to look at T cells and how they're reacting to Epstein-Barr virus. I don't think that's available in the United Kingdom, though. Just kind of going through, so there are simple things. So Akiko Iwasaki, she published it in September, I think, of 2023, low cortisol. Okay, so you have to first think about what a commercial lab is. So here in the United States, Quest, LabCorp, I live, on the West Coast, like Stanford has their lab. How good is that test? Because, are you going to detect what a really highfalutin lab at Yale University is showing? But cortisol is really low in people. You can give a little bit of cortisol to people. Same thing with thyroid. The thyroid gland, we do not understand. I'm just going to say that. So looking at the thyroid, giving a bit of thyroid can help. I'm trying to rack my brain. So for me, it's just a click. I just click, order all my labs. Looking at evidence of clotting. Again, not sure what's available in the United Kingdom. You can kind of go through Quest, but I like a thrombin antithrombin level. Can help me sometimes to see if that's what's going on. A paper very early on in long COVID, Adams TS13 to von Willebrand factor ratio is important. I look at a lot of mast cell markers. Mast cell activation syndrome. Everyone in the panel is like, yeah, like that's a thing. Like, that's not a thing that has been recognized on how broadly important that is to people. So we run a lot of mast cell markers on folks looking at histamine. So histamine and tryptase is very easily, every clinician under the sun would be like, that's what mast cell activation syndrome is, but there's a few others. I don't know what's available in the United Kingdom. Want to look at antiphospholipid syndrome, want to look at your micronutrient panel to see what's going on. Although that is really looking at the serum, not necessarily looking intracellularly. Inflammation wise, this is tough. So like a CRP and ESR, that's just like a poor clinician's word of like, hey, it's elevated. 99 times of the time, like on 100, it's not elevated. There are markers. So TGF beta 1 has been elevated. A lot of mold doctors say that it means mold, but it really means inflammation. An HSCRP might be helpful. I've seen that. Cytokine panels, you can get them through Quest or LabCorp. You can get them from other companies, functional medicine companies. I'm not sure what's available in the United Kingdom. So those are kind of initial labs, but it runs the gamut. I do want to make a plug real quick since you're in the United Kingdom. The team at Amatica Health, looking at HIF1 alpha. They have so many panels, and I think, if patients are watching this or doctors or other clinicians are watching this, like, I have so much hope. There are characters that I have met along this journey that are like, oh my gosh, you are doing that? Like you are trying your best to find diagnostic tests that prove what's going on. Because the horrible joke in long COVID is, oh, I went to my doc and all the labs were normal. Good thing there's nothing wrong with you. No, it's just the ability of a test to capture what's going on. I think just the last aside of like some of those more advanced tests, they cost money. Sure, insurance companies don't cover them. The NHS. I'm from Canada. I don't know how that system works, but it is a lot of money. But those are a few tests that you can maybe get from your GP.
And I'll also add in the UK, Regeneros Labs is another one that does a lot of the functional tests that we have available here in the United States, and a lot of them can be done with a self-ordering process with their in-house clinicians. All right. The next question that we have is, have you had any good results using Korean red ginseng? There was a study saying it helps some ME/CFS and long COVID patients.
It's it's funny. I saw this paper last week with ginseng. I haven't used it enough to kind of get that signature, but it's exciting. But again, how many randomized control trials like are out of that? I have my Korean side of my family, and so I just thought that was so funny because it has been a part of Korean medicine, and it I think just as a bit of an aside, sorry to take time. This is a bit of the issue in Western medicine on maybe how John and I have been trained. If it's a supplement or a herb, it's not like a treatment. That's wrong. We all need to get over this. They're called tools. And this is a randomized control trial. So anyone who's going to naysay it, hey, we just proved it. So to answer the question, I haven't. The only thing I can tell people, use a good brand of ginseng. Like, do not cheap out on your ginseng. That's just all I have to say on that one. So sorry, I can't, but I'm hopeful to use it.
I can say I have personally used it. It is a good tool for energy. It lasts a few hours. It's not something that's gonna, make you run a marathon or make you invincible. But in myself in particular, it has, that extra boost for a few hours. And I use particularly I think it's 1080. I'll put a link in the notes when we post a recording as well.
And in terms of this concept of drug versus supplement, it's really, really important. And personally, how I go through this is thinking, if something's been around for, tens of generations, there's some reason it's continued forward. And that may be a different kind of evidence than a randomized controlled trial, and doesn't mean it will work, but it does mean there's a lot of evidence around, is it safe or not to try? And so if it might work in the system, spot, and approach you're trying to go after, and it's not likely to cause harm, the treatment as part of diagnosis can be a really powerful action to say, all right, let's try it for 2 weeks. Did it make a difference? Did it do what we thought it would? Another example, you were talking about JAK stats, Dr. Malcom, and there's a drug that used to be available. You can still get it compounded, Amlexinox, that is essentially a JAK stat inhibitor, and that is it's dirt cheap compared to the branded drug if you don't have coverage for it. Or I think the brand antiviral for 5 or 10 days was about $1,300. A month of Truvada is $20, if that. And from an effectiveness in at this point, probably no single antiviral on its own is going to be effective because of immune that the virus can work its way out of it. But the concept of just because it's cheaper, it's not better is not necessarily true. It just means there isn't necessarily a group that has a financial interest in studying it and amplifying it with direct-to-consumer ads on TV. And so that's really important here, I think, as we're in this inflammation side of things.
Absolutely. A question for Dr. Malcom as well. What is your approach when you have a new patient who is on the more severe end of the spectrum? Someone who is housebound or bedbound, and perhaps has a lot of reaction to medications. Where do you start with that patient, and what do the subsequent layers look like?
I think what's hitting my brain now is to get genetic testing to see where that person is sitting. To be honest with you, that's kind of, I think I've been doing this for 5 years now. And I feel like I know less than anyone alive about this, but I also know a lot because there's just so many unanswered questions. I think first is how much mast cell activation is going on is one statement, because there are times where I'm like, hey, I got a tool, I got a medicine, like we're gonna do this, and it's a roll of the dice that they're gonna react. And I just got a message from one patient this morning that they reacted to something that no one has ever reacted to before. So I explained it as, hey, we're a team. Like, at first, it's kind of just like a personal thing. Like, we're a team. Like, that this is going to be very much like slower and like trial and error of like what we can do. Things like oxaloacetate to give a little bit of energy, like, could be helpful, but you have to start extremely low in these patients. It's really kind of this idea of like, how can I get you like maybe a little bit better so that you trust me? Or that, hey, now you have energy that I can like get you to the lab to get blood testing. Some patients are so ill, and this is, you know, the millions missing, that they're lying in bed all day, and my heart goes out to them. And I wish that this field had been more advanced by the time, you know, I came to it. But I take mast cell, and really trying, so there's something called the bicycle theory of mast cell activation syndrome, which is that the mast cell has several kind of holes in it, like a bicycle tire, and you need to really put a lot on. That would be one approach, but really you have to compound a lot of medicines and really make sure that there's not anything in there. Two is I need to know micronutrient wise what is going on with you. I am really jumping towards getting a genetic panel, like genome on everyone. That's kind of where I would start. I don't have a great answer for that, but that's just a few ideas.
I think you're on mute, Isabel. I don't know whether you were trying to say
Oh,
something.
I said anything to add, Dr. Haughton.
No, I think sometimes it's going back through the history also and really trying to figure out what's what. One person that I'm thinking about sticks in my head where not bedbound, but severely impaired to the, not being able to work and stuff. And in walking through the history, the indication of, oh yeah, if I scratch myself, it stays red, and which is, as people know, can be a real sign of mast cell, and that somebody had been undergoing treatment for a number of years and nobody had done mast cell trials, and antihistamines actually made a huge difference. It was super simple, but the answer in that case was much more just walking through the history. And I think the concept of a checklist is important. Here's somebody that's been is severely compromised functionally, has been through lots. Double checking and just going down the list methodically. Were each of these tried, and how do we know? That would be my suggestion on the approach.
And Dr. Malcom, where do you go with the mast cell treatment? Do you start a particular place? Is it customized? And what is on your toolbox for different patients?
Gotcha. Yeah. So I kind of think about logistics. So I have like a dot phrase. So a dot phrase in medicine is like in the EMR. It's just, like I'm going to forget them all. And there's just a lot. I usually start with an H1, H2 blocker, just because those have been like really helpful for people. I do like mast cell stabilizers, like Montlicast or Xylutin. Again, for people who are trying to get access, H1, H2, these are kind of like over the counter. Ketotifen, which is something that we offer through Rhythm Direct, has been helpful for people as well. It used to be over the counter. It's a pretty safe medication. Is helpful. The mast cell stabilizer, so that's Montlicast. There is an increased risk of suicidality. I have had a few patients say like, oh, I was really, saddened by that. But so H1, Zyrtec, or Xyzal, Claritin, Allegra, the H2, Pepcid, Ketotifen. Cromulin can be a game changer, but I have had people crash to it. And I hate that. I hate being a doc where I give medicine and it crashes. So that can be nasocrom, gastrocrom. That's been helpful. PA, luteolin, Dow enzyme with 15-30 minutes before meals. Amlexinox is a medicine you can get compounded in the United States. No financial vested interest, but Infuserve is a company that I use for that. It can cause some mild weight loss, but so you have to be careful in patients that have nothing, no weight to lose. Um, that's an option, but you have to pay for out of pocket out of that one, and I'm not sure if it's available in the United Kingdom or in Canada or elsewhere. And then there's just a whole bunch of stuff. So Beth Harris's Mast Cell 360, a lot of people have found perilla seed extract to be helpful. Boswellia are great things. I'm not the world's mast cell expert. What I know from them is it's trial and error. Some things work for some people and it doesn't work for others. I would say that the things that I'm seeing is that perhaps the GLP-1s are helpful for mast cell activation syndrome. And going back to what John was saying about the endothelium with the damage, the inflammation, and the mast cells coming in, statins I used to think was just inflammation, but there's papers showing that it stabilizes mast cells there. I counsel my patients, millions of people are on this drug. It can cause muscle pain. Monitor a CPK and an ALT on your CMP. Those are great options. But to go back to the GLP-1s, these are Zepbound, Mounjaro, et cetera, very easy to get in America if you are obese. Very difficult to get if you are not obese. And some of my patients are 100 pounds soaking wet. I am not in love with giving them a GLP-1, but we are finding these signatures that you can. And so there are a lot of companies out there where you can, take these compounded wise. I'm excited about that as a potential therapy. But all of those things, look at Mast Cell 360, eliminate histamine in the diet. I think the confusing thing as a doc in this field is how much of this is mast cell activation, where it's like sneakily there. Like the patients that I'm like, oh, you've got mast cell, like it's easy, it doesn't take a rocket scientist to figure this out. And other times it's like, oh, okay, well, we did the test, like it's obviously like involved with you. And patients are very educated and they're like, I don't think I have mast cell. I'm like, well, like actually let's try it. So it's very hit or miss. So I think speaking of like Dr. Yelman's former lecture, like it's necessary but not necessary but maybe insufficient to really treat someone, but you really need some mast cell meds.
And what about just along the lines of what about vasodilators?
Like, could you give some examples or?
Like say low-dose minoxidil or something like that.
Oh, I'll use that I haven't used a lot of it. I've used it for some of my patients with like the covetose or the Raynaud's or the myalgia. That has been helpful for some people. Um, I not as much as my other POTS medicines, I would say. But good point. Like the mechanism makes sense.
And just
We
along the
also
lines of potentially two parts of the mechanism. One is the small vessel changes that we've all been talking about, but then you also have small vessels on the outside of large vessels feeding them. And so if the health of the small vessel of the larger vessel is better, you can get a trunk level blood
Yeah,
flow.
I want to interrupt. So I often try to keep hydrated. I have my bottle in front of me at all times here, and sorry, it's kind of hard to see. The vasculature, and I kind of point this to my patients all the time. Here is the endothelium. What is going on? And I will, joke with patients like the glycocalyx. Gosh, that's complex biochemistry there. And the endothelium, what like is Bartonella living there? Is the microclots, is it damaged? What is surrounding the smooth muscle around there? There's so much biology to it. And I think I've focused so long on, hey, the only thing we knew was perhaps maybe Maraviroc and blood thinners. Okay, clear it out. But like there's a lot more biology here about how this works and how we get this to work again. And so that's a really good point. So I thank you for bringing that up.
we don't have any more questions in the queue, but the panelists have some questions in the chat. You guys want to ask your question? I see one about oxaloacetate and another one about pharmacogenetics.
Well, I have had pharmacogenetics done, and it's helped me understood so many of my bad reactions, or maybe if I took one of the drugs that goes through a certain CYP, I do okay. But if a doctor prescribed 2 or 3 and then I added an herb, then I've had all kinds of reactions. So I was wondering if you guys use pharmacogenetics. If you don't order it, can the patient bring it to you and you look at it? Medicare was able to pay for some of it, so that was helpful to know. They've done studies to show that in the ER, if they're given the wrong medications that they can't metabolize, then people will end in for hospital stays. So that's why Medicare got involved in doing that. So, do you use those bits?
Yeah,
Those
I
bits?
don't use pharmacogenetics separately because I'd rather, people will come with me 23andMe or Nebula or whatever, and oftentimes they'll taking a step aside, like what is a genetic test? Like, is it whole exome sequencing? Is it SNPs? How good, like
But
how
this isn't either of those because it's a separate kind of test that looks for splices that are missing.
okay,
Okay, and it'll look for duplicates. So regular whole genome sequencing won't pick it up, and
oh, gotcha.
won't pick it
Well,
up. It's very specific to the 26 genes that process medications as well,
gotcha.
and where they can check multiple locations. And so
I
they'll give you a label of you are a poor metabolizer of this class of drugs, or you are an ultra metabolizer. And it actually gives you a guideline of that means you need to start with 25% of the regular dose and that drug will work for you at that low dose. Or this person metabolizes it so fast, you might need 200% to make this drug work.
Yeah, then I think it's so hard because it's like, hey, we're still early on in long COVID of like, here's a drug that I know has worked. I used it on you and it didn't work. Is it just because your genetics didn't allow it or whatnot? That's really hard. And are the randomized control trials going to capture that as well is very just thinking outside the box. To answer your question, I've been more exploring kind of like the genetic profiles of like the acetylation and CYP and sulfonation and all that sort of stuff rather than the pharmacogenetic like panels. I think just also because where my brain has been at has been like it appears like the reactions are so idiosyncratic, but that could definitely be wrong. Like, and to get that data, and it is helpful that it can be covered even by Medicare. So, so to answer your question, no, I haven't been using it, but I will investigate that and try to understand in my brain of how it's different than some of the other genetic tests I do.
But to throw a wrench of that, my pharmacogenetics say that the medications that work for me should not work. So it's back to the patient.
I held off a little bit just simply because I've had people in the psychiatry field being like, everyone is just recommended to take venlafaxine. We don't think it's all that helpful. And so like, but that's the thing. That's a problem with medicine is, oh, I hear that this is no good, but no, like it can be really good. And yeah.
And the idea of of polypharmacy or poly supplements along with pharmacy rears its head all the time, and so kind of deliberately adding something and doing it slowly, and especially if it's something that might have a reaction that can be that you really don't want. So maybe with cromolyn, maybe you start very low with somebody and then boost it forward. Metformin is that way. That there are some people that just, especially as you get into the severe ME/CFS, that sometimes just have a really bad reaction, and so starting at a low dose, it may not really matter if it takes 2 or 3 or 4 weeks to get up to a more standardized dose.
As far as, and metformin's a good example there because it doesn't have as many of the CYP interactions, but it does go through one of the carnitine transporters, which is another one of those genes that's overrepresented in our population. And I found that in terms of medication reactions, if it's not a strictly metabolic process, the carnitine transporters and the glutamate receptors tend to be the largest variables. So a lot of those meds where you have that sort of donut hole response, where you have lots of really good and then, a couple of really bad and not much in the middle. That's where I'll look for those.
Gotcha. No, I hope that this conversation, wanted to make sure that we answered questions for patients because I know how hard this is, but for other clinicians and people who are thinking about this is like the number of times that I've stepped and fallen and made mistakes about things and not thought about things, like people should learn from that. And the first time I ever reached out to John was, using metformin. And I was excited about using metformin because there was a paper in Nature that was saying, hey, it can help the endothelium. I think it does other things, obviously. But I was like, this is an endothelial disease, I'll use it. And it just doesn't really work in my patients. But then, you know, as Kat's saying, it's like, no, like this is a pathway. And you need to understand the biology of each patient. And that's what I hope, because I think that long COVID and ME syphilis is a purely scientific thing of like, oh, it's an exciting time, people are publishing things. It has to translate to someone getting medicine or a supplement or a herb. And that clinical translation is really tough right now. And I hope to, from those comments, it's inspiring in my brain. Oh, like I made those errors because I'm, you know, trying medicines, but they might not work, not because they're not working, but because of other reasons. And I hope that other people are hearing that from our conversation here.
There's another question about cystanche and ginkgo biloba. There was a study saying that it helps some ME/CFS patients. Have you had any experience with them?
Can you spell cystanche? Sorry.
CISTANCHE.
We do have one person in the R50 that's used cystanche and did have a positive response, but you know, that's only one.
Yeah, I don't know. So again, I know a lot less than a lot of people because I just because of how deep I'm in it. I don't know this one, and so thank you for bringing this up. I'll have to look up that paper. Never used it. I'd be interested to know what the mechanism is. Ginkgo, I have used in people. It's been kind of hit or miss. I think there's a biologic reason for it, but it hasn't been this big game changer in my mind in a group in a lot of patients. But maybe it can be. I mean, that's the kind of the whole point of this, unfortunately.
And then another question, well, not actually a question, but just mentioning that Dr. Eccles in the UK is doing research on links with long COVID and hypermobility. And what is your experience in the clinic with the overlap of patients?
Oh, yeah, I mean, it's so profoundly clear that some people have hypermobility. I think that the hard part, so I would refer back to, you know, Dr. Yelman's video that you did with him on all of the physical manifestations like of this illness with the CCI and the atlantoaxial instability. Really just generally we have a bowling ball and a toothpick and the ligaments hold it there, and from the biochemistry of ME and long COVID, we're degrading them if they already have a hit. So for those patients, you know, if you have a bobbly head, if you push down on your head and things change, you might have CCI or something like that. Really seeing someone that knows what they're doing in terms of like, we got to get imaging to look at the tethered cord or the cranial cervical instability is really important. That is still extremely controversial in medicine. One of the questions about like, how do we stay up to date on like on this research? You know, we have a team. This is all day long. I just see papers or whatever. The Bayman Horn just released a clinical guide actually for clinicians, and it does talk about the biomechanical processes. So take a look at that. And it'll talk about kind of imaging that you can do. But really the hard part is that I tell people is the logistics are hard, getting into a doctor, getting this ordered, getting it covered through insurance, and then you get a result. And hey, you were laying down when you had your MRI. Did you have it in extension and flexion? Maybe getting it upright was important. Are you even well enough to get this imaging? Is it even capturing maybe the movement in this area of the head that may actually be transient? So we're really at the beginning stages of this, in my opinion, but you can get MRIs. It's just more, I think, logistically, go see your doctor. Hey, I'm concerned about this. Can I get an MRI? Show them a paper, show them that guideline to convince them to do an MRI, because it takes, at least in America, it takes a while to get kind of approval for certain things, and you really want to get it done correctly. So that's how I think about hypermobility. There's obviously mast cell, there's obviously like lots of things, but like the structural issues really go high in my mind.
And the inflammatory responses obviously can break down connective tissue as well. And so that's important. And one of the things sort of early on in this process, I thought all roads led to just tamp down inflammation, period. And you kind of worry, hey, are you going to end up letting cancer run wild because of or viruses run wild? But I think if you go into the wound healing literature, it becomes really important to quiet things down as well as let them open back up. And so the HIF-1 and the inflammation also does give you the endothelial growth factor, the VEGF, which grows new blood vessels. And if you think about it, how does the body get oxygen into places that it doesn't have it? The concept of inflammation and tunneling makes intuitive sense and lines up with what VEGF-1 or VEGF does and how hypoxia drives HIF-1 into the nucleus. And so it's important to sometimes walk through the nuance of what are you doing when. And so is it cycling on, cycling off, quieting inflammation, but then letting it go is maybe part of the rebuilding process as well.
Yeah, we are out of questions in the Q&A. If you, Dr. Malcom and Dr. Haughton, can end with whatever remarks you may have, but I would like to ask you to include in that, try to think about, the beginning of treating long COVID and ME/CFS as a doctor who didn't have much information about it, and was working within the constrictions of the systems that we have. What advice do you have for clinicians who do want to treat these patients, but really don't know where to go, how to get started, what to do first and what to do next?
Gotcha. It's tough. So I guess I would say I started my journey by, I had patients of mine that were I'm an internist by training, that were my primary care patients, and they got long COVID. And I said, I'm not smart enough to do this. I don't know what's going on. And then I just kind of fell to the bottom of the internet, Twitter and Reddit and all that sort of stuff, reading the papers, and I just started trying. And that's kind of started, and I just started medicine. And I think in when the microclotting theory was coming out, I did that. And that was a very hard time, feeling like that I might hurt patients, but that I thought that in my heart that was the right thing to do, because I thought that this is the largest disabling event in the history of humanity, that I felt like I had to do my part. I think what I would say is, look, there's Canadian guidelines now. Drugs like LDN are easy to do, that you can start there. Look at the Bateman Horne Center for kind of like, hey, there's the whole biomechanical kind of like issues. How do you treat POTS? Clinicians are not as familiar with like protostigmine. It sounds like a scary name, but like it's actually a pretty easy drug to use. How do we pace? What are things that we can use to help with fatigue? Is somewhere where you can start. But I think if I'm going to be very kind of like, pontificating here, clinicians need to come to this point of what we're taught in graduate school, which is half of what you know is actually wrong, and the other half maybe is incomplete. We are in a system where I only get 15 minutes as a primary care doctor to handle someone, and sometimes they just need someone to listen to, but they might have 10 problems. And we're all running around with our head cut off. You know what I mean? And then long COVID happened, and we were ignoring ME/CFS. There were people working on it, but it wasn't as much as we needed. And so I think that coming to, why did I learn all this biochemistry? Why did I learn about the mitochondria to never think about it again? What is these potential woo-woo things of chronic mold or chronic Lyme disease? I've always gone into this process to believe my patients, and I was very saddened when people were psychologized. It was like, it didn't make sense. How could millions of people all of a sudden be sick? This isn't hysteria. So I think that we need to kind of really, my recommendation is you know, be curious about things. You see a lab. Oh, I don't understand that lab. Do I have an hour to understand that? I don't know if you do. I don't know if you have that time because of the system. So I would say be open-minded, look at those guidelines. You can start easy. The guidelines will kind of have things that you can start easy, but it would really, you need to talk to your bosses about, can you give me time to learn about this illness? You know, I'm doing all my CME, continuing medical education. I have to do training on opiates. I don't have a DEA license. I don't give opiates. Why does my board of medicine make me do that? So you need time. There needs to be time to do this, and it needs to be kind of like a commitment that you make, but there are easy things you can do to start off with, and be open-minded and realize, hey, what we've learned might actually be wrong, and to kind of keep going. So yeah.
Thank you so much, Dr. Haughton.
Yeah, so I would say to try to have something that makes sense in your back pocket that can be done in a safe way and can be tried for 2 to 6 weeks to see what's what. And so if you have somebody coming in and the story makes sense, then quieting inflammation, getting blood flowing, a potential simple way to do it is curcumin or turmeric. So high dose turmeric for once a day, nattokinase, maybe 4,000 units once a day to work on the microclot side of things, and some antihistamines. And maybe it's a Pepsid and one of the H1s, or just even one by itself, and just try that. And if somebody's all of a sudden feeling better after a week or 2 weeks or 3 weeks, then you might be on the right track. And if not, that also can give you some information. And so I think there's a way to do something safe and try as a trial that may be helpful, and the result can be helpful.
Wonderful. Well, thank you both. Thank you, everybody, for attending today. We've come to the end of the roundtable. Again, thanks to Dr. Malcom and Dr. Haughton for this wonderful conversation. We will post the recording to our YouTube channel as soon as possible. And thank you, everybody. Please share this material with your providers. The more providers we have looking at this and understanding and learning, the more that this pool is going to open, and we're going to have more opportunities to be treated, which is what we need. Thank you. Have a great day, everyone.
Thanks.
Bye.